I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, now I want to cover heparin-type products. So heparin and enoxaparin, these are the two main medications that I'm going to teach you about. Enoxaparin, I would say in my experience, I see this used much more frequently than heparin, but heparin you will see used periodically as well. These are considered blood thinning, anticoagulant type medications. The big difference between like DOACs and warfarin and enoxaparin and heparin is enoxaparin and heparin are injectable type medications. So enoxaparin, brand name Lovenox, mechanistically it works in that clotting cascade, primarily inhibits factor 10A, but also has some blockade of thrombin, that would be factor 2A. Okay, so by blocking those factors, those clotting factors, we're going to thin the blood out. The big downside, on a chronic basis, if you will, this medication would have to be given as an injection on a chronic basis, okay? So that's why you really don't see it out in, ambulatory care and out in practice. It can be used for DVT prophylaxis, both as well as treatment. Higher dosages for treatment, which is pretty much true with, just about any anticoagulant compared to prophylaxis dose, which tends to be lower. All right, some other things. So careful in patients who have a history of heparin-induced thrombocytopenia. Enoxaparin is enough of a cousin. The body thinks it looks pretty similar to heparin, and in heparin-induced thrombocytopenia, there can definitely be cross-reactivity there. So you generally wouldn't use enoxaparin if you've got other alternatives available if a patient has had heparin-induced thrombocytopenia. So pay attention to that. And obviously, if somebody's prescribed this and they've got that HIT background, heparin-induced thrombocytopenia, definitely be sure to address that with the attending provider. Rarely it may contribute to hyperkalemia. Remember ACE inhibitors, ARBs, spironolactone, or aldosterone antagonists. These can all raise potassium levels. Enoxaparin, it's not something I really think of strongly, but there is that potential. With both enoxaparin and heparin, bleeding is going to be the most common complication. So, assessing our patients for any type of, blood loss in the urine or the, gut or out into the stool, those type of things is going to be really important. We can bridge, and that's sometimes often done. So let's say we want a patient on warfarin. We may use enoxaparin in the short term because warfarin doesn't work right away, and then eventually bridge that patient over as we're giving enoxaparin, start warfarin, and ramp up that INR. And then once we get to target range, we can discontinue the quicker acting anticoagulant like enoxaparin. Converting to and from DOACs, sometimes called NOACs as well. Simply start the one in place of the other at the usually timed dose that you're going to have. One unique thing about this medication is it is derived from pork or pigs. So, certain cultures may not desire to take this medication because of that, or their religion won't allow them to utilize this medication, and so we may have to look at other anticoagulant type options. And also pregnancy. So if we've got a patient with DVT in pregnancy or at risk for DVT and we need prophylaxis, whatever the case may be, which does happen occasionally, low molecular weight heparins are generally preferred. All right, moving on to heparin, and then I will take a peek at heparin-induced thrombocytopenia. I think there's some important things to know there. This binds antithrombin 3, which enhances the rate of inactivation of factor 2A and 10A, again, affecting those clotting factors in the clotting cascade, leading to a blood thinning effect. The kinetics on heparin are a little bit more unpredictable, so, the breakdown of the medication and those type of things, and so that can be a little bit challenging, to get the right dose and to not, overdose the patient and increase the risk of bleed too. We may do some monitoring of activated partial thromboplastin time, so that's APTT, or potentially anti-factor 10A levels as well. So those are a couple monitoring parameters you may see checked if heparin is being used. Treatment dosing is typically done via IV, and obviously this is usually done within a healthcare setting. The sub-Q administration of heparin is typically going to be used for prophylaxis. One unique thing, potential advantage here with heparin is in renal failure. This medication may be a little bit more advantageous than some other medications that are anticoagulants. Good little test nugget to remember, protamine is the antidote, and then there is a potential fish allergy co-reaction risk, and then again, similar to enoxaparin, it is a pork-derived or porcine-derived product. And hyperkalemia, I alluded to that with enoxaparin. Also, osteoporosis is associated with heparin. There again, it's probably only going to be due to long-term use, which the likelihood that somebody's using heparin long-term is pretty low at this point now with all the other anticoagulant medications that we have. All right, so I wanted to make sure we go over heparin-induced thrombocytopenia. This is one of the biggest concerns with heparin. And then also maybe to a slightly lesser extent enoxaparin, but the risk does exist there. There's two types of heparin-induced thrombocytopenia. So we're talking about platelets dropping, and that's something that's going to be assessed in lab work, generally within a CBC. So making sure that those platelets are monitored if you've got a patient on heparin, very, very important. So type 1 is a mild drop in platelets, less than 30 to 50% typically, and it happens quickly after starting the medication. Usually that's just something we monitor for and pay attention to. Obviously, if it drops crazy low or something, we're going to have to pay attention to that. But if it's just a mild drop, it's likely considered to be more type 1. Now type 2, this is kind of the classic big concern with heparin-induced thrombocytopenia. So we get a big drop in platelets. That's likely due to type 2 heparin-induced thrombocytopenia, usually greater than 50%. So if you've got somebody that's, well over 300-400, and now they're dropping to less than 100, that's a good example of, potentially heparin-induced thrombocytopenia from heparin or enoxaparin. Okay, it's usually a little bit of a delayed onset, so after a few days typically. So when people refer to heparin-induced thrombocytopenia, it's usually type 2. Okay, this is much, much more clinically concerning than a mild drop in platelets on type 1. The big reaction you get from this, it is an immune type reaction, and Despite the drop in platelets, so those platelet levels go down, patients are actually at risk for blood clots. It's kind of a unique paradoxical reaction there. Again, less risk with enoxaparin, but if somebody got heparin-induced thrombocytopenia from heparin, you wouldn't transition that patient over to enoxaparin. So paying attention, understanding that history, and the biggest, most important thing here with the use of heparin and enoxaparin, making sure those platelets are being monitored. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse.